Welcome everybody. We're here today for the Research into Practice webinar series, where each month we introduce another one of our research units who focus on a particular theme, and they present to us about current research that they're doing and how that might impact the clinical practice and care that our colleagues give in the Trust. Today's webinar is about perinatal mental health and parenting. That's Prime RU is what we call it, and the lovely Henna Lemetyinen will be presenting for us. Just to clarify, I'm Emma. I'm the Communications and Engagement Officer for Research and Innovation, and we're joined by Henna Lemetyinen. He's a Research Associate for the Perinatal Mental Health and Parenting Research Unit. I will now hand over to Henna for her presentation.
All right, thank you, Emma, for the introduction. I'm not sure how much you already know about perinatal mental health already, so I'd just like to set the scene a little bit so that we are all starting from the same page. So motherhood is a time for psychological change. We call this change matrescence, and it encompasses the different psychological, social, cultural changes which occur as women transition into motherhood. So for some, this transition goes really well, but perinatal mental health difficulties are very common. Up to about 27% of mothers experience mental health difficulties during pregnancy and up to 1 year postnatally, which is what we call the perinatal period. Perinatal mental health difficulties increase the risk of poor outcomes for both the mum and the baby. So, for example, risk of suicide increases, and it is the leading cause of death in mothers in high-income countries. Mental health difficulties can also impact attachment and bonding and affect an infant's development quite globally, such as their emotional and cognitive development, for example. So this is why effective intervention is really critical for the women and for families as well. So what happens if we don't intervene? Not intervening has that human cost that I was just talking about, but also a considerable economic burden. So according to some estimates, not treating perinatal mental health difficulties costs the UK about up to 8 billion a year. In 2016, most localities in England failed to offer effective community care to women with severe perinatal mental health difficulties. And that same year, a strategic nearly £300 million investment into new specialist perinatal mental health services was announced by the UK government. And in 2021, over 80% of perinatal mental health community teams across the UK were providing psychological interventions. So service provision is looking considerably better than it used to. So coming to our research unit then. The Perinatal Mental Health and Parenting Research Unit, or PRIME for short, as we call it, or PRIME RU, was founded as a research response to the service provision expansion to support clinicians, academics, and commissioners by strengthening the perinatal mental health evidence base. So we know that historically women's health research has been underfunded, and we know that mental health research has been underfunded as well, but we want to see that change. PRIME was established 5 years ago, so in September 2020. Like most GMMH research units, PRIME is a collaboration between the University of Manchester and GMMH. It's directed by Anya Witkowski, who is a professor of clinical psychology and a perinatal clinical psychologist in GMMH. During this 5-year period, we have been involved in over 10 research projects, but in this presentation, I will focus on 2 studies to give you a flavour of our work. Our aims as a research unit are to improve mental health care and support for parents. We want the offered treatments to be supported by robust evidence. We also want parents to gain skill and confidence in their parenting. So next, I will tell you a little bit about the digital assessment of well-being in new parent study that we call DOMP. This is a study that has just recently finished, so it's not ongoing anymore, but we have some findings to share, which is exciting. So now let's focus on postnatal depression, or P&D for short, for a moment. So systematic reviews and meta-analysis show that about 17% of mothers develop postnatal depression, as to about 7 to 9% of fathers. Similar to what I mentioned earlier, postnatal depression can negatively affect the whole family and has a considerable economic burden on the society as well. More than half of P&D cases are currently undetected and thus untreated. The NICE guidelines recommend that clinicians should consider using 4 brief screening questions, and then they should be followed by full screening if symptoms are detected. But we argue that that phrasing of the current recommendation should consider has potential for adding bias and inequality in who are screened. So, for example, these case finding tools, so for example, these 4 short questions, may not be culturally sensitive and may not detect symptoms in parents from other minority groups as well. A review from 2 years ago found that universally administering the full screening was more effective at identifying P&D cases than initially using the 4 screening questions and then doing the full screening for a subset of women. So to tackle this problem, we developed a P&D screening app. The app prompts parents daily to answer the 10 questions of the validated Edinburgh Postnatal Depression Scale, EPDS, which is used in standard practice. And the app uploads their answers to a secure server where the research team can log in and see their responses. The standard EPDS asks about the person's mood for the past week, whereas our smartphone app asks about the past 24 hours. So this allowed people to answer while things were fresh in their mind. This reduces recall bias, but also with digital screening, we aim to address some of the other known barriers to perinatal mental health screening, such as lack of staff time for screening and also language barriers. The app is available in 4 languages: English, Arabic, Urdu, and Cantonese. And a graph of the user's recent mood scores allows them to view their mood over time. The app also contains links to helpful resources and some emergency phone numbers as well. But please note that this app is not publicly available yet, so you won't find it in your app store. So there was an initial proof of concept study, which involved developing the first version of the app and testing it with 23 mothers and a handful of partners. It wasn't a controlled study, so it was just to see whether the app works at all. The proof of concept study indicated that the idea of using an app for postnatal depression screening has some potential. So next we obtained funding to do a feasibility randomized control trial, RCT, to test the methods for a full-scale study evaluating the app in an NHS setting. So the proof of concept study was like a really mini pilot study, and then the feasibility RCT is like a bigger pilot study to assess whether there's potential in this app. So we examined whether such a study would be feasible, acceptable, and safe as well. And so I hope this analogy works for you. So one way of understanding the research question of feasibility study in particular is by analogy with a party. So it might be a bit unusual, but just please bear with me. I hope it will make it a bit clearer. So if you were evaluating the success of a party, you might look at things like feasibility. Did people come to the party? Did they fully engage with the party activities? Did they stay until the end? Things like that. Acceptability could be thought of as, did they enjoy the party? What did they like the most and what did they like the least? And then the final question is around safety. Did anyone get hurt at the party? But before we started the pilot trial, we needed to refine the app based on feedback from the proof of concept study. And we also refined some of their study materials. So we had some workshops with parents and healthcare professionals like GPs, psychologists, midwives, health visitors, etc., to refine the look and the use of the app. The app considerably improved from the version that was tested in the proof of concept study. So for example, the newer version now included an animated video explaining the purpose of the app, and it also included some inspirational quotes collated by our patient and public involvement group. and a graph, which I mentioned earlier, that displayed mood scores per week, per month, and all time, so that it's easy to see how your mood has changed. We also really wanted to make the app and the study more accessible to people who might otherwise be excluded, such as people with limited English and low literacy. So to do this, we had the participant information sheet translated again into the same languages that the app is available in, so Arabic, Urdu, and written Chinese. And we created a video version of the participant information and added subtitles in those 3 languages. We also created a video showing how to use the app, and we also added subtitles in those 3 languages to that video. So we really cared about the accessibility. So now on to the pilot RCT methods. So this is a bit long, so please bear with me, but I'll just try to be as clear as possible. So we recruited participants to the feasibility RCT from late pregnancy onwards, so from 36 weeks of gestation. We had 2 recruitment sites, St Mary's Hospital in Manchester and then Wiston Hospital in Merseyside. People with existing anxiety or depression at baseline were excluded because the purpose of the app is to detect emerging depression. So the app would have been redundant for those with existing depression. It wouldn't have been suitable for that purpose. After the baseline assessments, participants were then randomly allocated to receive digital screening, so the app, alongside their usual care, or just to usual care only group. For those in the app group, a research midwife helped them download and set up the Care Loop Dompy app, and we asked them to use the app until their baby was 8 weeks old. If participants screened positive via the app during this time period, we assessed depression and anxiety using standardized measures, PHQ-9 and GAD-7, to confirm whether it was a true positive screen. And then true positive screens were then referred to their GP and health visitor for support. We also checked case notes weekly for both groups to identify positive screens in usual care, and again used PHQ-9 and GAD-7 to confirm true positives. So the purpose of this activity was to check the app's performance against the standard screening practice to see whether they match up. At 8 weeks postpartum and 6 months postpartum, we conducted blinded clinical and health economic assessments. And those in the app use group were also invited to give some qualitative and quantitative feedback on the app at 8 weeks postpartum. And here you can see a little summary of our sample as well. We are very, very proud of our diverse sample. It's quite rare in studies to have such ethnic diversity. So, for example, around half of participants identified as white and around half as being from an ethnic minority group. And around a third reported a native language other than English. And we also looked at the indices of multiple deprivation based on participant postcodes, which indicated that participants live in areas of high deprivation, which again, we are improving at this front in research, but it's really lovely to see that we managed to recruit such a diverse sample. So on to our questions evaluating feasibility. So the first thing we look at is recruitment. Did people come to the Dompy party? If we stick with this party analogy. And luckily they did. So we aimed to recruit 80 and we actually recruited 76. We were so close to meeting our target, but we just had to stop recruitment for pragmatic reasons. But if you look at the graph, you can see that we probably very, very likely would have exceeded our aim if we had been able to recruit for even just like for 1 or 2 more weeks. And second, we look at the app engagement. Were people engaged in the Dompy party, so to speak? And yes, they were. So we met our a priori criteria for sufficient app use. So overall, we were looking for at least 33% of daily app assessments to be completed, whereas 55% were completed, which was really nice to see. We were also looking for more than 50% of our participants to complete at least half of the app assessments, and we exceeded that as well, with 65% of participants doing so. That was also really good to see. Then we also had really excellent retention. If we're sticking with this party analogy, nearly everyone stayed until the end of the party, so to speak. So 92% of participants completed the assessments at 8 weeks postpartum and 91% at 6 months postpartum. So that's really good. So there's only 1% difference. And huge credit of that goes to our really, really incredible research assistant, Dami, who still works in GMMH in a different study. She worked super hard to build rapport with people and keep them in the study. And that was one of the things that we had really good feedback on from participants as well. Then if we look at the outcome completion, that was a little bit more mixed. So we tested 2 potential outcomes that we are trying to choose between if we were going to do a full-scale study. So the first candidate outcome relied on weekly data extraction from case notes, which I mentioned earlier. Pragmatically, it was just really, really difficult. We had so many logistical challenges around accessing electronic case notes from 2 trusts, which meant that only 45% of data that we needed and was extracted on time. And although we did eventually get access to everything that we needed, it just became evident that a primary outcome in a study cannot rely on prompt case note data extraction. It's just not suitable. So I'd say this was the hardest part about the study. Then the other primary outcome that we tested was the mini psychiatric assessment completion for major depression, generalized anxiety, and suicidality at 6 months postpartum. And for this one, we met the criterion for data completeness. So that seemed like a better potential primary outcome for a full-scale study. Then if we look at acceptability, did people enjoy the party or the app? We measured acceptability of the app using a standardized rating scale that assessed the acceptability and usability of apps called the Abridged Mobile App Rating Scale, or MARS. It has 7 items that are scored from 1 to 5. The median score in our sample is 4 or 4.1 actually, which is pretty good if you think about it as 4 out of 5 stars. So that's kind of like the review for our app. But if we look at the individual item scores, which you can see there in that bar charts, you can see here that participants found the app easy to use, but not interesting. And we found a same pattern in the proof of concept study as well. And also this was reflected in the qualitative feedback we received as well. And it seemed like people understood that the app was for a specific purpose. They didn't enjoy using it, but it was kind of helpful potentially. And then the final thing we looked at was safety. Did anyone get hurt at the party, so to speak? So we systematically monitored adverse events during the study and recorded 5 serious adverse events and 77 more minor adverse events. Most events were related to the mum or baby's physical health, either during pregnancy or postpartum recovery. 12 adverse events were mental health related. So we always collected information about these events to assess whether they were related to the study. And none of the events were judged to be related to the app or the study procedures. So we consider the app to have been safe. And then we also gathered qualitative feedback, like I said, but we haven't fully analysed these data yet. But one emerging theme seems to be that the app helps new parents to take a couple of minutes each day to reflect on their mental health when they are doing the daily assessment, the EPDS questions. So the DOMP closed in August, and we are working on the outcome paper, so please stay tuned for that. Okay, next we are going to talk about another study that we have ongoing at the moment called OPAL, Parenting Intervention for Perinatal Mothers. We are going into the world of parenting now. I'd just like to preface the next study by introducing you to the concept of positive parenting, so then you can see kind of where we're coming from. I think you will recognize this description, but maybe you just don't know the term itself. So positive parenting is not unified, clearly defined term, but it attempts to describe a group of parenting behaviors or traits that are considered beneficial for child development, such as sensitivity to the child's cues or needs that are met with a nurturing response. And evidence-based parenting programs can benefit both children and their parents as well, short-term and long-term. And there's a lot of evidence-based supporting this. There are several parenting programs out there, but I'm just going to focus on an Australian program called Triple P, Positive Parenting Program. It's a big umbrella of programs with separate strands for different types of parenting, so parents of infants, parents of toddlers and older children, etc. So here, I'm not going to talk through all these different studies, but I just wanted to give you an idea of all the work that goes into developing just one strand of a program. So this is a timeline where you can see the evidence base for the baby version of the Triple P program, including both face-to-face and online modalities. So the baby program is aimed for expectant parents and parents of under 1-year-old babies to support transition to parenthood. It's a universal program for all parents of babies, so it's not just for those who are at risk of parenting difficulties. Some of these studies have focused on mothers with perinatal mental health difficulties, which is really exciting. But all of those studies so far have been with the face-to-face format of the intervention, except for the OPAL study at the very end of the timeline, which I will tell you about next. Something I wanted to highlight was that nearly 3 years ago, the Australian government rolled out the Baby Online program to all parents in Australia as a public health intervention. And there is an ongoing national evaluation, but the data are unfortunately unpublished. So it would be really interesting to see the impact and see whether it's something that could be applied to a UK context as well. So what is OPAL? So it's our ongoing live study, online parenting intervention for perinatal mothers. This is an uncontrolled pilot study. So in the DAWN-P study, we had a control group. In this one, we don't. This is a very small pilot study. The aim is to offer access to the Triple P for Baby online program as an additional intervention to psychological therapy within the GMMH Specialist Perinatal Service, which is a community mental health service. Similarly to the DAWN-P study, we are interested in the feasibility of participant recruitment and engagement, and also in mothers and staff's feedback about the study and the program. The findings will then again inform potential for a full-scale trial. So what does the intervention actually entail? It's a self-paced online course, which is accessible on devices with internet connection. It has 7 components or sessions covering different aspects or topics relevant to the first year of parenting, like understanding your baby's behavior, communication, activities you can do with your baby, communication skills for couples, stress management techniques, and so on. The content is mostly in video format, so it's quite accessible also for those who struggle with literacy, for example. So the method of the study is quite straightforward because there's no randomization. Like I said, there's only one group of participants. So we receive referrals from the specialist perinatal service staff, and then we screen and consent interested and eligible women and birthing people. After baseline measure completion, participants are given access to the online program, and we ask them to complete the program in 10 weeks, but they can keep accessing it for a year after starting, so much beyond the study, which is really nice as well. Participants then complete post-intervention measures after that 10-week period, and they are also invited to complete a satisfaction survey about the program and also invited to a qualitative interview about their experience of the program and the study. Here's a brief timeline showing the key milestones of the study. So we started participant recruitment in May, and our recruitment deadline is in December, and the study will close at the end of February. So it's a very, very short study, like I said. Here's our progress to date. So to date, 64 women and birthing people have been approached by their care teams. 46 have expressed interest in the study, and 25 women actually have been recruited, and then 20 have enrolled to the parenting program, and 2 have already completed it, which is really great. So our work is still very much in the early stages. So we have delivered or are delivering feasibility studies, and we want to scale up and obtain funding for full trials so that we can actually know whether the things that we are studying actually work. Are they actually clinically effective? Another real difficulty is implementation. So we need to develop a clear idea about the implementation of our specific work. So for example, in DOMP, we would need to have a clear idea of how the app would be implemented in services before we even tested it in a full-scale trial. Same with implementing the baby triple P within the perinatal context specifically. I haven't had time to talk about our patient and public involvement, unfortunately, or experts by experience, but we always actively involve several people with lived experience of perinatal mental health difficulties. And our plan very much is to continue to involve them in when we are designing the studies and when we're conducting the studies to make sure that our work is relevant to the public. And finally, for our work to be impactful for GMMH, Greater Manchester, England, and the UK, hopefully maybe even internationally, we need to develop really excellent competitive funding applications, as do all of our research units, but that's one of our core functions. Okay, I think that's the end of my slides.
Great, thank you so much, Henna. I will kick it off with a question we received ahead of time. Could you share your career journey so far, including what led you into perinatal mental health, any key turning points or challenges, and what helped shape your decisions?
Wow, that's such a flattering question when someone actually asks about me. Thank you for whoever asked that. So I have always worked in psychological research. So I did my PhD quite a while ago. I graduated in 2015. And I did my PhD on developmental psychology in child language acquisition. So something quite different, but it was still sort of family focused. But I never did anything language acquisition related post PhD. I just decided it wasn't the route I wanted to go down. And then I was very fortunate to get a job with, I don't know if you know Professor Dawn Edge. I worked with her for a long time on her culturally adapted family intervention studies. Worked with her for at least 5 years, I think, across the University of Manchester and GMMH. And then I wanted to do something that combined my developmental psychology experience with sort of family-focused intervention experience. And then this job with Anya in Prime just came up internally, and I applied for it because I felt like that was a really good match with the different kinds of research experience that I had. And that's how I ended up here. So I have been involved with Prime since the very beginning when it was founded. So I started in September 2020 in this current role. I would say that absolutely the biggest challenge is also, even currently, always is research funding, because our field is still really quite niche. And when we are applying funding for our research from NIHR, which is the research arm of the NHS, we often are competing against grant applications of all kinds of health, cancer, dementia, cardiac health, all of this. And sometimes it can be really difficult to keep you in the job when you don't have research funding. So I'd say that is definitely the biggest challenge. But on the upside, like I said, the services have expanded, and hence the need for evidence base is also expanding. So in some ways, I do feel like we are in a better position now than we were a few years ago. Yeah, I think from the top of my head, I would say those are the sort of key points. Thank you for that question. I appreciate it.
Yeah, we actually had Dawn speak last month about CAFE, so that has recently been part of our series. Another question I had ahead of time here was, what are your plans for the Dawn P study or our app next? Because we know it's closed now. Yeah.
Yeah, that's a good question, because we are kind of figuring it out ourselves. So I hope what you got away from this presentation was that the feasibility trial was really successful. I would say what we are currently doing is, after the outcome paper, we are hoping to apply funding to do the full-scale trial. We just need to make some decisions around, for example, what the suitable primary outcome would be. and just tweaking maybe the app and the study design based on participant feedback, which we are still analysing, so the qualitative interview data. But we are very keen to continue developing it.
And do you think if we got to a stage where a full-scale trial was formed, and how would you think Dawn P would end up being rolled out or used in services? Would you think it would be available for everyone if they wanted it, or would it still be kind of behind some walls?
Yeah, well, this is the other really interesting question, because it would depend on how it would be used. This is one of the questions we actually have to settle, which is, we've received some conflicting feedback from parents and from healthcare professionals, because, well, we did a sub-study, which I didn't mention in this presentation, but 30 healthcare professionals working perinatally were interviewed about what they think about the app, and they are really adamantly against using it as a tool that would alert healthcare professionals about someone's mental health difficulty. They think it would be much better suited for self-monitoring, whereas parents themselves kind of think they are open to using it only for self-monitoring purposes, but they also really like the idea that if they score very highly on the EPDS, meaning that they are experiencing symptoms of depression, that app would directly alert a healthcare professional known to them, like, for example, their health visitor. So this is another thing that we have to reconcile somehow before we actually apply funding for the next Dawn P study.
Thank you. So we've got to the end of our previously asked questions. This is just the final slide, a little bit of a pitch for our department as a whole. We've got a really great website for research and innovation, which tells you how staff and service users and members of the general public can get more involved in the research that we're doing, what the kind of research we're doing is. There's a library of all of our studies where you can go and see maybe if one of them is suitable for you. That could be staff or as a participant, for example. And we have our social media accounts where we post any published research that's recently come out, any studies that have recently opened, or more events like this one, as well as some of our news. Above all, we really love to hear from you. That could be, I've got a research idea, I'd like some help, I would just like to know more about events, or, could I refer somebody in? Any of that. If you contact us at askaboutresearch@gmmh.nhs.uk, we will happily get you in touch with the right member of our team and hopefully start a discussion. We've got another set of webinars. These continue to happen every month. So the end of this month, we've got the psychosis research unit. And in October, we're looking at having the youth mental health research unit, JUICE. So it's been really interesting to see the depth and variety of research that's going on, and the specialisms that sometimes they're just not part of the skill set that we're currently working on. So just dipping in and seeing how different that is and where there are similarities as well. So we hope we can join us in one or a few of those things. Thank you again so much, Henna, for your time and explaining those studies to us. And I will release you for the rest of your afternoon. We hope you have a lovely, lovely afternoon and rest of your week. Thank you, everybody.
Thank you, Emma.